how powerful they are if you go 20 years and you still haven't developed breast cancer. Well, the Gale model is very accurate for populations. It will take, if you take 13,000 women, it'll tell you how many women out of the 13,000 are going to get breast cancer. It does a little overestimating, but it's totally acceptable. The problem is it can miss the mark when you use it on an individual. And most of the time it hits very nicely, but it can miss the mark. You can overestimate, and it overestimates risk because it doesn't take into account the ages of the relatives. It also counts biopsies, old breast biopsies, as a risk factor, and the more you have, the greater the risk is. But a lot of women have had multiple biopsies, and there's nothing in the tissue that imparts an increased risk for breast cancer. And so you can generate some pretty high numbers with a very low risk. It also underestimates. You can have, if you have a family that has the breast cancer gene, that it can be coming through the father's side, for instance, and you may not have a first-degree relative, so it can underestimate your risk. And the key is knowing how to spot a list of risk factors and say, whoops, the Gale model isn't going to work on this patient. Let's go over to another model, which I thought was the next slide, but it's not. This is a ad campaign that began shortly after that little Gale model was passed out to every OBGYN in the country. And it was to get, and then direct consumer marketing by the makers of tamoxifen to get women to ask what their number was. Are you a 1.7? They didn't tell anybody what a 1.7 was. I didn't meet many physicians that knew